throughout this series, you'll meet many staff here at Winnunga, and people will then understand why Aboriginal health is important to be in Aboriginal hands. I grew up in a small country town called Winnunga in New South Wales. I'm a Wiradjuri woman. I was one of six children. I was the number 4. And I had four brothers and a sister. My father was a truck driver. My mother was a housewife. But, we had our struggles when we were young. I went to Whitton Primary School. I went to Leeton High School. I didn't get my Year 10 certificate. I got married when I was 19. I had 4 children, and I was an alcoholic. My youngest son died when he was 8.5 months old from cancer, and rather than take Valium, I started to drink, and I ended up with a problem. And in 1985, I actually got my life together. I got a job in the Department of Aboriginal Affairs, and I was there. I was also there for the inception of ACT. I was fortunate enough to work for Robert Tickner when he was the Minister for Aboriginal and Torres Strait Islander Affairs for 3.5 years. Then I went to OATC, the Office of Aboriginal and Torres Strait Islander Health, and I just lasted about 6 weeks. I took a redundancy and I went to the Canberra hospital as the lone Aboriginal liaison officer. I was not only there for the inception of ATSIC, but I was also there for the demise as a regional councillor. As the Aboriginal liaison officer at the Canberra hospital, I could see that there were lots of things that wasn't right in this community. I worked on the National Aboriginal Health Strategy when I worked in the Department of in DAA, and I helped organise to get all the CEOs and chairpersons of our Aboriginal Community Controlled Health Services to Adelaide to have a meeting and to strategise for the NARS. Then I was there for the implementation process. I was there when the report was released in Robert Tickner's office, and a lot of good things happened back then. I was involved in the Royal Commission into Aboriginal Deaths in Custody, writing up recommendations, also bringing them home. When I worked for Robert, John Stanhope, who's now a senior advisor to myself and the board, and the former Chief Minister of the ACT, he actually worked for Michael Lavarch at the time, and our offices almost faced one another, and we never met in Parliament House. So it's been pretty amazing. I got involved in Winnunga back in 1993. The founder of Winnunga, the late Olive Brown, her and Dr. Sally Creasy and Carolyn Patterson, who was a midwife here at Winnunga, they organised a temporary clinic at Grevillea Park in 1988 when the Queen visited Australia, to actually our mob mobilised to come in and protest against, human rights, health, education, land rights, all of those things. So the temporary clinic was set up to look after them. From there it went as a part-time clinic at the back of the old Griffin Centre in the city here in Canberra. And then in 1990 we got a permanent home, and that was at the back of the Griffin Centre. And it was an old car park was fenced off. We had about a 3 foot wide path, and we had a mesh fence with barbed wire around the top. So, and our clinic, we only had 2 back doors. We didn't have a front door, and it was a it was a difficult place to work. There was a lot of disadvantage. Often we'd walk out and someone would be injecting, heroin was really bad at the time, or we'd come into work and there'd be syringes stuck in the fence, and it was really, really difficult. So, you know, back in, when Olive passed away, I was a board member, and then in 1997 I went in as the administrator. And my role was to actually have Winnunga relocated and co-located. The CEO, a research person and a part-time finance person was over in the Moore Street building, in the health building, and myself, Dr. Peter Sharp, and a receptionist and 2 health workers were in the back of the Griffin Centre. And it was a very, very threatening place. So I actually started to, and my brief was to have us relocated and co-located, but also our budget back then was $291,000, and I knew that $50,000 of that was going to pay for the ALO position at the Canberra Hospital, because the funding was coming as a specific purpose grant from the Commonwealth to the ACT at the time. So I actually then started to have meetings at the Griffin Centre with the bureaucrats. I had us relocated and co-located in March 1998, and I went in October 1997. The CEO resigned when we moved over to Ainslie, and I ended up becoming the CEO. I took 6 months leave without pay from the hospital to get us relocated and co-located. And so it's 18 years in October that I've been the CEO of Winnunga. Today, yep. Winnunga is a service that provides, we provide services to over 6,000 clients. I have 68 staff, an $8.5 million budget, and it's been an amazing journey, you know, and it's been, I've been fortunate. In the early days, we had a bit of, you know, we always get community politics, and back in 2000 we ended up in the Supreme Court, where there was a ghost board set up, so there was 2 boards of Winnunga, and what happened was that we ended up in the Supreme Court, and they left me there as the CEO and appointed an appointee to open up the membership and run a special general meeting. But, you know, today we have a board that knows what a board does, and that the board don't get involved in the day-to-day business. They are very clear about their role, that they provide the strategic direction. And I think that that's probably why we're one of the most successful Aboriginal Community Controlled health services, and that we've been able to consistently have low risk when we've been assessed by the Commonwealth, but also we're multi-accredited. And that was one of the briefs that we had when we moved to Narrabundah, was the board and I put a lot of effort into accreditation, and also data, making sure we had a robust data system. So today I can go to our data officer and ask her to give me a profile of our clients and what are the biggest issues that are impacting on our people. Recently we held an ICE forum here at Winnunga. There was around 200 people, a lot of community people. We have a huge intravenous drug problem in this community, and it was great to see that so many people turned out and come and wanted to learn more and to be educated about what ICE is doing and the impact it's having on a lot of our families in this community. I think that often because we live in Canberra, a lot of these things fly under the radar, because Canberra is a very prosperous place. You know, we're probably one of the wealthiest cities in the world, but there's a real underbelly in this community. And ICE, and you know, in years gone by it was heroin. And, you know, when people were on heroin, they'd pretty much go on the nod. But with ICE, we never know what we're going to be faced with, you know. When people become aggressive and psychotic, it's very, very difficult to manage. It's a very different drug to heroin. So, you know, we've been able to, you know, we're probably one of the best services at managing the risks associated with ICE. And that's because we know our clients. the risk for us is the clients that we don't know, the people that come from interstate or other people that access the service. They're a bit of an unknown quantity. So it's a bit about how we keep everybody safe. We need to keep the affected person safe, but most importantly, we need to keep the families and the people in our waiting room safe. So, you know, we have an addiction doctor and an opiate nurse and a mental health nurse where we can quickly move people that are psychotic through the service. Sometimes we have to call the police. It's not our first option, and the police know that. And so when we call, they know that, you know, we're in trouble, and they come straight away. But, you know, it is, and I know that it's having an impact right around the country, but it's ripping families apart, and we all know that drugs don't discriminate. You know, it doesn't matter whether you're rich or poor or whether you're black or white. You know, an addiction's an addiction, and ice is a very addictive drug. There's no substitute for ice, whereas with heroin, you know, you can substitute with methadone and other substances. But with ice, you know, what I learnt was that it's not a 5-day fix in detox. It's actually 2 weeks. People need to be kept safe and off it for 2 weeks. And then it can take up to 2 years for people to recover from it. So, you know, that's really important for us to know. And it's important for me to know as the CEO of Aboriginal Community Controlled Health Service is how then we support those people and those families.